So let's talk about some physiology when we talk about OSA. So, of course, the classic thing we think about when you say OSA is always the overweight individual. And I don't know if there's any Star Wars fans listening today. This is going to be Jabba the Hutt, the big intergalactic gangster from the planet of Tatooine. I can't believe I just said that. That's so dorky. Oh my God. But anyways, of course, look at that thick neck circumference and big tongue. But what is going to be the physiology when we talk about OSA is that here's going to be the tongue, here's going to be the upper airway over here. This is nasal, this is oral, pharyngeal, and it goes right here. And of course, if the tongue is too big, it's going to narrow it here. So how do you get the collapse? It's really based upon two physiological principles. The first physiological principle is called the Bernoulli principle. The other is called the Venturi effect. And both of these kind of go hand in hand. And let's kind of break this down so you will understand what's the physiology behind collapse of the upper airway in OSA. So let's talk about the Venturi effect first. So this area right here is kind of the narrowed airway in the back of the mouth. So this area that I'm circling right here is going to be right here where it's really, really narrowed. So what happens up here is more proximal. It's going to be air coming in through the mouth and the nose. Air is going to flow through that really tiny area, that constricted area, maybe because there's a thick neck, then go distal. So what happens is as air goes through this little narrow area here, that it's going to have an increase in speed, an increased velocity. So when you have this increased velocity through this narrow area over here, it exerts less pressure to push open the collapse. And that's why when they put a measurement here, look how much more pressure is exerted when you have a big lumen versus a small lumen. So this small lumen represents this area back here in the back of the mouth. And that's why you don't, with that very high velocity and speed, you're not be able to push open the collapse. That's called the Venturi effect. That's kind of combined with something called the Bernoulli principle. So notice if you have a higher speed and velocity going here, well, it's going to create a vacuum. The vacuum effect is called the Bernoulli principle. So when I switch the slide over here, how do you explain that Bernoulli principle? Well, think of this straw right here in this wonderful, tasty chocolate shake. Now, what's a good example? I don't know if anyone listening has ever been to like In-N-Out Hamburger. That's like the big popular hamburger place here in LA and California. And I gotta tell you, I do love it quite a bit. And when I'm sipping their chocolate shakes and I really get a big sip in there, what's going to happen is like this area right here. I'm creating an increase in flow through this narrow tube, and the vacuum develops. And what happens to the straw when you sip a very thick chocolate shake? It collapses. That's called the Bernoulli principle. Another way of thinking about it, of the Bernoulli principle, could be when you're at home, at nighttime, the air conditioner kicks in, and all of a sudden air starts going through the door that has a little crack in it, but you didn't close it all the way. And what happens when air zips through that door? It creates that vacuum. The door just what? Boom, slams. And if it's nighttime and it's Halloween, which is coming up, you're going to be scared. So this is going to be when we talk about the Bernoulli principle over here. So this is something that I guarantee you'll see on the boards one way or another, is that we take these concepts that we talked about, Venturi effect and Bernoulli principle, and we put it into what's called the upper airway Starling resistor model. So once again, here's going to be the lumen. So this is going to be the posterior pharynx, the airway. This is going to be the neck around it, and it says P crit. That's the critical closing pressure. So what's going to happen is that if you have a thick neck circumference, that it's going to squeeze in the lumen, and the lumen should be patent, so air could flow from the upstream pressure, that's what PUS stands for, which is like the nasal and oral, through the posterior pharynx and go distal, of course, into the trachea, which is DS stands for distal pressure. So what happens is if your lumen pressure is greater than the pressure that's trying to squeeze it, then you have zero flow problems. Flow is going to come in from the nose and the mouth and go into go downstream to the trachea. When are you flow limited is when the critical closing pressure exceeds the pressure that's distal and you get a collapse, and that's called a hypopnea. But if you actually have the P crit, the pressure being greater than both the upstream and downstream pressure, then you have a complete collapse. We call that an apnea. So that's what they're showing over here. So with that being said, now that you guys mastered the OSA, the pathophysiology, a couple questions, let's talk about treatment. So a 54-year-old man has a home sleep apnea test because of snoring, obesity, and sleepiness. Makes sense. Assuming that the 2-minute compressed epoch below is a representative of the entire study. So it's the home sleep study, and it's a compressed 2-minute epoch. And what am I looking at here? This is the flow, so there's no flow, and down here is going to be effort. So no flow with effort, no flow with effort, no flow with effort. And you can notice that the saturation is going up and down and up and down, kind of correlating with these no flow states. This is classic for what? Obstructive sleep apnea, especially if the entire study is indicative of this 2-minute epoch. So which of the following is the most appropriate next step in this patient? Well, does this patient now need to do a polysomnography, which is a split night, to re-diagnose and titrate? That doesn't make a lot of sense to me. You already made the diagnosis. Does the patient need a multiple sleep latency test? I don't think so. MSLT, I mean, we're not talking about narcolepsy or idiopathic hypersomnia. No, I don't think I'm going to do this. Can you start an auto-titrating CPAP? I think the answer is why not? You have the diagnosis of OSA. Bringing the patient back to the lab to do a titration kind of contradicts why we didn't bring the patient in the lab to begin with, to do the diagnostic. I mean, obviously there are certain times where if you feel they're on, supplemental oxygen or other comorbidities, you may consider doing that. But, in this case, it just sounds like you should give AutoPAP, which really, it pairs well up with an HSAT. And reassurance, no. I mean, there's a reason why we did this study. The patient needs to be treated. So the answer here is going to be what? C. There we go. So when we talk about obstructive sleep apnea, what are going to be some treatments? I think that, I wanted to mention some lifestyle modifications first, because even if it's not spelt out on the board exams, it's always going to be assumed you do these lifestyle modifications first. Sure, I put weight loss over there, but of course, being obese or overweight is not a necessary criteria to diagnose OSA. And you got to be careful, because nowadays with weight loss, people are using a lot of these GLP-1 analogs. So I'm sure we've all seen commercials for Wegovy, Ozempic, Mounjaro. So do it the old-fashioned way if necessary, and of course, many people do bariatric surgeries. So of course, weight loss may help out. You do want to avoid things that will kind of weaken the upper airway, things like alcohol sedatives. Of course, opioids can do it also. And of course, I believe positional sleep apnea is such a huge thing, and positional therapy is so important. And it's really, really important in the elderly, because as you get older, it's hard to use dental devices because they may not have any teeth, and as you get older, above 65, you may not tolerate CPAP as well. So in some individuals, who knows? I think that's a big point of research, is using positional therapy. And a lot of these positional therapies are FDA approved that are out there. But of course, the mainstay therapy for OSA is always going to be, non-invasive positive airway pressure. We have CPAP, which is continuous. We have BPAP. Remember, we don't call it BiPAP, because BiPAP is kind of like a brand name. Like when you have a cola, there's like Dr. Pepper and Coca-Cola and Pepsi. BiPAP is kind of like a brand name. We just call it BPAP, and it's going to be a bi-level pressure. And that could be with ST, spontaneous and timed. You could have a bi-level ASV, where the inspiratory pressures are adaptive servo ventilation, or you could have a bi-level where the inspiratory pressures are AVAPS, which is going to be average volume assured pressure support. And we'll talk about these last two shortly. So no one should be surprised. Not everyone tolerates PAP therapy. And I believe that even though PAP is the gold standard for therapy, that there's got to be better ways to see what's going to be the right device for different individuals. So other options could be oral appliances, specifically mandibular advancement devices. There definitely could be things that you like surgery. The classic surgery many, many, many years ago was something called the UPPP, which is the palintopharyngeoplasty. There could be the hypoglossal nerve stimulator, which goes by the brand name the Inspire device. And of course, a tracheostomy will bypass the obstruction. But there are other things too. So up here in the top, you see these kind of stickers you're putting over the nose over here. The brand name is Bongo. Kind of don't like the name, but they used to be called Provent. And what is this doing? It's kind of providing a little peep. So these stickers, when you breathe out, it gives you some positive and expiratory pressure to blow back and keep the airway open. Bongo is reusable versus Provent, which was not reusable. Many of you may have seen brand name Excite, which is the first daytime therapy for mild obstructive sleep apnea and snoring. You have to put this in your mouth for, a certain amount of time per day. And, it's, unfortunately it's not covered by insurance, but it's always nice to have new options, and it is FDA approved for mild OSA and snoring. And of course, this is the classic Inspire device where, usually our ENT colleagues will consider this. There's very specific criteria I would do on the board exams based upon BMI and collapse of the upper airway, based upon doing something called drug-induced sleep endoscopy. So we definitely have a lot out there nowadays. And I'd even put down playing the didgeridoo. Just joking. Don't answer the didgeridoo for the board exams. So I wanted to say, what is DICE? So, of course, when we talk about surgery, there's a neuromuscular evaluation that surgeons, ENT doctors do. Historically, we do things invasive. Of course, non-invasive. It's still an evaluation. Is our role for MRIs and CTs that are dynamic to help, make a decision for the type of surgery. But for right now, we do invasive things. The classic way is when patient was awake in the olden days, you tell them to pinch your nose and breathe in, and you would see a collapse of the other upper airway when they have a little scope in there. It's called the Mueller's maneuver. It's the opposite of the Valsalva maneuver. But of course, the problem is the patient's awake. It's not really indicative of sleep. So what we do is DICE, drug-induced sleep endoscopy. So usually they'll come in the outpatient setting, they'll put an IV, they'll give some midazolam or propofol, and they'll scope. And when they scope, they're going to vote. And what does vote stand for? V for velum, O for oropharyngeal, T for tongue, E for epiglottis. And you look for the type of collapse you're going to get. If they have more of a soft palate collapse, just in broad strokes, maybe some modified version of a UPPP. If there's a lateral wall collapsing of tonsillectomy, we talked about concentric collapse for people who are obese. If it's going to be collapse around the tongue base, that anterior posterior collapse, that would be a candidate for the Inspire, given if their BMI is under a certain limit. And then, of course, E for epiglottis. And it's weird to not have an epiglottis, but someone could consider like a partial epiglotectomy, even though it's not a very common thing that ENT doctors do. So back to questions. So an oral appliance would be most appropriate for use in which of the following conditions? Would I use it if you have obesity hypoventilation syndrome? Probably not. There'll be an elevated CO2. I don't think that's the person will benefit from an oral device. Would it be someone who has mild to moderate OSA? I really like that one. Would you use it for central sleep apnea? That sounds like a bad idea. You're not even, with central sleep apnea, you're not even initiating the breath. So I wouldn't do that. And severe OSA, sure, maybe we all had patients that we don't have anything to offer. We could consider using it. But if we're going by FDA approval, it got FDA approval for mild to moderate OSA. So the right answer here is going to be B. Wonderful. And I put some things of when do we think about it clinically. Of course, if there are individuals that prefer oral appliance to CPAP, doesn't surprise me. Maybe they don't respond to CPAP. Maybe they're claustrophobic, many failed attempts. So, and of course, you could combine, oral devices with CPAP, oral devices with other behavioral measures such as weight loss also. So, which of the following measures have been shown to enhance PAP adherence? So I'm going to go with, this is a gimme on the board exams. Which one of these will make our patients more compliant? Is it using a bi-level positive airway pressure device? That has to be wrong, because if really we had better compliance using a bi-level, well, everyone is going to be on the bilevel, so it has to be wrong. CPAP with what they call expiratory pressure relief, EPR. So, and they have different names. I think some companies call it C-Flex, but what happens at the end of expiration is it drops the pressure, and it drops the pressure probably a maximum of 3 centimeters of water, because anything more than 3 centimeters of water should be considered kind of like a bilevel device, But this is more for comfort, and if it really showed to have better adherence, everyone should be on a high pressure relief setting. So no. Ramping mechanisms, kind of ramping it up, the answer is no. And actually, some people with severe OSA, they don't even like to be ramped. They want to be at the pressure they need right away so they can fall asleep. Heated humidification, now that's a tempting one. I remember when I was a fellow, I used to think, wow, I was just ingrained in my mind that humidification improves compliance, but the answer is no. It's actually a comfort measure, and of course, it prevents you from getting the dry mouth and everything, but it doesn't help out with compliance like we thought. Using a nasal mask interface compared to an oral full face mask, you know what? That is actually a correct answer. And they did studies to show that definitely wearing a nasal as the first shot will definitely give you a better chance than doing a full face. F, behavioral support educational stuff, 100%. We need to do these things. So the correct answer is going to be G. It's going to be both E and F. So let's go over these. So don't forget that when we talk about humidification, always use distilled water. Just put that there. And which of the following is a benefit of auto titrating CPAP over traditional CPAP? Is it A, a greater reduction in the apnea-hypopnea index? Answer has to be no. If that was the case, then everyone should be on AutoPAP. It has a less negative impact on sleep architecture, meaning that it gives you more REM or more slow wave sleep. The answer is no, or else all of us should be on AutoPAP. Would it give you better saturation? Not really. If it was, then we should all be on AutoPAP. Now, does it give you lower mean airway pressures? The answer is yes, because it's going to auto titrate. So the answer here is going to be what? D. Outstanding.